Brought to you by Biologically.
Ladies and gentlemen, welcome to this edition of Conversations. Today, we have a doctor, and not just a doctor. He has over 22 years of clinical experience with extensive experience in management of critical care, quality, and inpatient safety. Dr. Sateesh Kumar is our guest for today. An alumni of the Indian School of Business, Hyderabad, he is a critical care specialist, anesthetist, and emergency medicine expert in advanced hemodynamic monitoring and management, advanced mechanical ventilation strategies, management of ARDS, severe sepsis, septic shock, and multi-organ dysfunction syndrome. Dr. Sateesh has extensive experience in different aspects of hospital management, including manpower planning, selection, facilities administration, cross-divisional coordination, and liaison with external bodies for smooth running of the hospital, prompt patient care services, and development of patient-focused well-being policies and strategies. Today, Dr. Sateesh is going to speak on the subject of deep vein thrombosis. With the World Thrombosis Day scheduled on the 13th of October, with a theme, Eye on Thrombosis, we have Dr. Sateesh taking a set of questions from us and telling our viewers about his knowledge, his specialization, and his advice on how to treat a deep vein thrombosis. Let's start.
Hello, Namaste all. Thanks Mr. Suresh sir for giving me an opportunity to talk on thrombosis, which is really a devastating disease and which is not being actually caught in the routine management of the patient in hospital. Thanks for giving me this opportunity. Let us go ahead.
Dr. Sateesh, as a critical care specialist, how often do you get patients with deep vein thrombosis? I mean, what is the periodicity to which you get these kind of patients coming in?
Thrombosis is that there is a clot inside the blood vessel. So now specifically the terminology told it is deep vein thrombosis. The thrombosis happening in the deep venous system of the body. Say it is in the popliteal system, say it in the iliac vessels, say it in the major vessels. So that's why we consider this as a deep vein thrombosis. But normally it should be clarified that any vein that is visible from the skin is a superficial venous system which does not have an active role in this thrombosis. It may have a thrombosis, but it does not lead to the devastating issues. Deep vein thrombosis, there is a clot inside the major venous system. At any point of time, it will get dislodged and it will go into the venous system. It slowly propagate and go into the right heart, and it might stuck up in the pulmonary artery, leading to the major pulmonary thromboembolism, which is one of the emergency life-threatening situations. Unless we tackle this, there is every possibility there is high mortality and patient likely to die because of this disease. So this is very important disease to be considered as a medical emergency. Often we miss the diagnosis.
Dr. Sateesh, that actually gave us a good opening into the entire scenario. Now the DVT, as we call it, deep vein thrombosis, how does it really happen? Because you did speak a bit about it as a start into the entire thing, but in terms of receiving the number of patients who turn up, as you rightly said, it is a life-threatening disease. But how often do you get it, and what exactly is this? I mean, in layman's language, what would you say it is?
So, to have a deep vein thrombosis, normally we have the entities like chronic immobilization, patient who is in the ICU for more than 24 hours, patient who is on ventilatory support. These are all the prerequisite conditions to have a deep vein thrombosis, where there is definitely sluggish circulation happens. Circulation is not active in the venous system. And when the patient is, example like we can say that long-term air travel, like when people traveling to US, 14 hours they are sitting idly. That is one thing, there is a possibility there is a sluggish circulation which enhances the clot formation. So normally in the medical side we say that it is a varicose triad. So immobilization, sluggish circulation, there is some inflammation inside the venous system. All these things contribute to the deep vein thrombosis. But apart from this, there are other risk factors, like there is a disorder in the blood systems, like there is a possibility of some hereditary disorders, factor 5 laden deficiency, protein C, proteinase deficiency. So all these things might lead to inherently having a prothrombotic state. So that is a diseased condition. But patient who is not having an as such disease may have a deep vein thrombosis because of these risk factors, like patient who is in a chronic immobilization, long bone fractures, who is having inherent cancers, and elderly age group. All these things are risk factors to have a deep vein thrombosis. But if you say that in general public, if these patients are having these risk factors, there is every possibility they will get it. Otherwise, any patient who is hospitalized in ICU for more than 24 hours, who is on ventilatory support for more than 24 hours, there is every possibility these patients will land up into deep vein thrombosis. So that's why in a patient who is in ICU, we definitely look into these aspects, like to prevent this, we use these patients on anticoagulants. Usually these patients are kept in anticoagulants as long as their stay is there in the ICU.
Yes, Dr. Sateesh, I often remember people telling that, when you're on a long haul flight for 16, 18 hours, these kind of conditions come up. But as a specialist, you are aware of what this entire thing is all about. But there are many general physicians who are really not aware of DVT and how to identify patients who come in with DVT. I mean, is there a way in which these patients can be identified? And as a general physician, when they look at a patient, how do they know whether this patient has a DVT or does not have one? How do you look at that?
So, DVT wise, when the patient approaches a doctor with the following symptoms, like patient is having a unilateral limb swelling, one limb is swollen, one limb is became red, and there is a risk factor to have this, what I told you previously, like long-term travel, long bone fracture, having a pre-existing cancerous diseases, all these things should trigger that this patient might have a DVT. So these are the things, like clinically, if you see that there is a limb swelling, unilateral limb swelling, which is already having a chronic immobilization, and now the patient is having some breathlessness, new onset, which is not related to any heart disease or lung disease as per se, there should be suspicion that this patient may have a DVT.
Well, Dr. Sateesh, yeah, you're right. You said swelling of the limbs and redness and other factors do come into account. But quite often, the DVT may be mimicked by other diseases. It may or may not be that. But in case the doctor gets it wrong and he imagines that the DVT is not there and he starts treating for the other kind of diseases that are present, because quite often they are mimicked, are there any inherent dangers if it is left at that point in time? What, according to you, are those dangers?
Sir, I take your question into two parts. Part one is, what are the investigations that supports this diagnosis? So thing is, having these, normally we call it as Wells criteria or Geneva criteria is there. So Wells criteria, they say that these are all the 7 risk factors. Having these risk factors, we go into the probability assessment, mild probability, moderate probability and high probability. So having these risk factors, then we subject this patient for a D-dimer, is one of the blood investigation. If the D-dimer is high, there is a strong suspicion of the DVT. It has a very good negative predictive value. If the D-dimer is negative, we can rule out a DVT. If D-dimer is positive, these patients should go for a higher investigation scan. The gold standard investigation is CT pulmonary angiogram is the gold standard for this. If the patient CT pulmonary angiogram showing some clot inside the pulmonary arteries, yes, it is a pulmonary embolism. And one more thing is the investigation of choice is we have to go for a lower extremities venous Doppler ultrasound and compression ultrasound. If it shows a clot inside the major blood vessel, major venous system of the limbs, then we can say that this patient is having a DVT. This is the suspicion followed by an investigation probability assessment. Coming to the next part of the question. So how best we can organize? Yes, definitely it is a very, very dangerous situation. If the patient is having a deep vein thrombosis, there is every possibility that clot will dislodge and go and stuck up into the major pulmonary pulmonary arterial system and leading to sudden breathlessness and death. So most of the hospitals may not have a chance of going for a CT pulmonary angiogram. At least we need to go with certain basic investigation like blood gases. Most of the times blood gases are normal in this DVT, and normal blood gas does not rule out a DVT or pulmonary embolism, though patient is hypoxemic. The second level of investigation is ECG. ECG may show there is a specific pattern called as S1Q3T3 pattern, but all pulmonary embolism patients may not have this investigation also. So it is also not a conclusive investigation. Then the easiest thing can be done at the bedside is doing a 2D echogram. If the 2D echo is showing there is a right heart enlargement, RARV dilatation, pulmonary arterial hypertension, or there is a tricuspid regurgitation, these things indirectly say that the patient having high probability as per the clinical aspects, then corroborative evidence with these investigations may clinch or add to the diagnosis if the CT pulmonary angiogram cannot be done. So, having a high probability, having a risk factor, limb swelling, Doppler positive, T-dimer elevated, CT pulmonary angiogram is the level of investigation we need to come up. If CT could not be done, at least we have to do a 2D echo and find out the right-sided heart failure, right-sided heart events. Then we can easily diagnose this pulmonary embolism because the treatment is very, very easy and life-saving. If you just give an anticoagulant, patient will survive.
Dr. Sateesh, you really took us to that diagram. You split the question into two parts. One is about the kind of tests that need to be done to confirm whether it's a DVT or not, and then kind of got into the basic part of how the treatment procedure can be organized. Now, my specific question to you that's coming up is, what is the actual treatment for DVT? I mean, what exactly do doctors need to do to treat patient with DVT? Are there any specific treatment procedures?
Yeah. Treatment is very simple, sir. It is low molecular weight heparin or any heparin derivatives. Unfractionated. There are three varieties of things what we really available now. It is first thing is unfractionated heparin. Second thing is low molecular weight heparins and newer oral anticoagulants. So normally we start the patient with the injectable unfractionated low molecular weight heparins like enoxaparin or dalteparin. So once it is stabilized with that, then we will slowly switch over to oral anticoagulants like coumarin derivatives or vitamin K antagonists like acetrom or second thing is we can also go with this injectables at home also. But the patient should receive this treatment for at least 3 months in an unprovoked DVT, and the patient is having a risk factor like a cancer or something really creating a thrombus inside the body, prothrombotic situations, it has to be used for lifelong. So the mainstay of treatment is low molecular weight heparin, subcutaneously to be given initially therapeutic dose of 1 mg per kg body weight twice daily. And once the situation is under control, then we have to switch over to oral anticoagulants and discharge the patient to home and with the follow-up of investigations.
Dr. Sateesh, I mean, you really described the treatment procedure for us, but quite often deep vein thrombosis, the patients who have deep vein thrombosis do get treated, do get cured, but there is a tendency for them to get it back again. That is, there might be a repeat of it. In such a case, what do you think can happen? Is there a possibility, and what do you, in your extensive career, you must have seen a number of cases like this. How does it really work? I mean, is there a chance of this happening? And if it happens, what are the procedures to be done?
As I previously discussed that there are two entities, unprovoked DVT and provoked DVT. Unprovoked DVT is DVT happened by itself. We don't know why it has happened because if just some risk factor is actually playing there. There are certain situations where there is an internal pathology. We have to look into etiology of the DVT. Why this is happening? Is there anything that is triggering prothrombotic state in the patient? That is what we call it as patient who is having a existing cancer inside the body. Patient who is having a constantly thrombus formations like protein C, protein S deficiency, high homocysteine levels. All these things are prothrombotic states. If these things are there, we need to have a constant monitoring and treatment lifelong for these patients. If this an unprovoked DVT happened like a long duration flight travel, that itself is the reason for the DVT. So first of all, identification of DVT is one thing, and we need to identify the etiology of the etiology means what is the reason for this DVT has happened in this patient. If we identify the reason, treat the cause, then the DVT will not relapse. If we don't know the reason, and it is, we can't call it as an unprovoked DVT, and we just give it for 3 months of anticoagulation and we just follow it up. If it is a provoked DVT, we find that there is a definitive etiology like patient is having a prothrombotic status. Treat that condition, DVT will not relapse.
Deep vein thrombosis. You heard Dr. Sateesh explain in detail about the various facets that DVT comes up against and what treatment procedures do doctors and specialists have. I'm sure you have a lot of questions that may come up post after hearing this video or this podcast. What I would request you is to write into the email ID that will be described along with this telecast or the podcast. And surely we'll get Dr. Sateesh to answer your questions to the best extent possible.